All right. Thank you, everyone, for joining us for what I hope you will find to be a very special Grand Rounds. I now have the pleasure of introducing Dr. Julie Hauer, who is currently serving as an assistant professor of pediatrics at Harvard Medical School and at Boston Children's Hospital. She's also the medical director of the Seven Hills Pediatric Center, which is a long-term respite care facility for children and young adults with severe neurological injuries or impairment. As a clinician scientist, Dr. Hauer has revolutionized the care of children with severe neurologic impairment. Her research and writings on symptom management, including pain, gastrointestinal symptoms, dysautonomia, and dyspnea in this population, has provided many physicians, including myself, with a roadmap for how to improve the comfort and quality of life for these children. She is also focused on how to create models and systems of care for these patients by creating guidelines for the American Academy of Pediatrics and through her book entitled Caring for Children Who Have Severe Neurological Impairment, A Life with Grace, which addresses their medical and palliative care needs. On a personal note, I first heard Dr. Hauer speak at the American Academy of Hospice and Palliative Medicine when I was a fellow. I was so taken by her thoughtful and practical approach to the care of these children that I have since made it a point to follow her on PubMed, read pretty much everything she's ever published, and attend every talk she gives at our mutual conferences. She is an icon in the field of palliative medicine, a true role model, and I am so very honored to welcome her as our Grand Round speaker today. Dr. Hauer, please take it away.
Well, Scott, that was very humbling and greatly appreciated as an introduction. I wish to thank Amy Hotro for the invitation. Amy and I are co-authors on the AAP clinical report that Scott mentioned, and also the department for supporting this Grand Rounds. I have nothing to disclose. My objectives with this discussion today are first and foremost considering both the etiologies and the mechanisms of pain transmission that are different between acute and chronic pain, to consider the language strategies we use with parents when both introducing and managing chronic pain, and also the role of developing care plan strategies for breakthrough symptoms. I focus on children with severe neurological impairment, and to better understand or describe this group of children, there's now an initial working definition that was developed through a Delphi process and published last year, that these are children with disorders of the central nervous system that result in both motor and intellectual disability with associated medical complexity. I start with this slide that just depicts the longitudinal nature of recurrent pain and chronic pain in this group of children. And I'll break this down into components, but it really, to me, is important to start because it requires a commitment from us as individuals, how we look at this population as teams, and then how we consider strategies as a system, given that such children interface with many providers and many locations of care. I also want to start by just putting more of an emphasis on chronic pain by recognizing in this group of children, as best we know from the literature, that those with the greatest impairment have a high rate of severe pain and frequent pain. So if you look at the population that has gross motor function level 4 and 5, and intellectual disability of severe and profound intellectual disability, that as best we know that at least half of them have weekly to daily pain, and that pain is rated at a high level. Chronic pain is difficult to identify given that it's more insidious, in contrast to acute breakthrough pain that reaches a threshold of concern periodically. And then finally, chronic pain is so important given that it has a profound impact on both the quality of life of the child and the family, as well as having an impact on health of both child and family. So starting with acute versus chronic pain, what I really want to emphasize here is both the differences in terms of the etiologies and the mechanistic transmission of pain when we look at acute versus chronic. So acute pain is typically nociceptive sources that generate tissue injury and tissue inflammation, and then that results in a protective pain signal to alert to a problem that's in need of identification and treatment. These are sources that can be identified by history, exam, and diagnostic tests. And then when we identify the problem and treat it, we'll have resolution of the problem and the associated pain. In contrast, children with severe neurological impairment are also at risk for aberrant pain signal generation due to the altered nervous system, which will be a chronic form of pain. The challenge is that in this population, there are no tests nor diagnostic criteria to indicate when it's due to the altered nervous system, and that given that we can't eliminate the cause of symptom generation, our goal of treatment is symptom modification and control, given that we cannot cure the problem. I want to delve a little bit more, particularly into the chronic pain component, and I will briefly touch on nociceptive sources. Again, given that the problems with pain generation due to the altered nervous system, and given that there are several reasons why that can occur, I want to propose a term Neuro-Pain to get at the mechanism of pain transmission. And the reason I propose this term Neuro-Pain is that there are chronic pain sources due to the altered nervous system in children with SNI, again, without diagnostic tests or criteria, but as importantly, without distinct features to differentiate one from another, and that they often occur with other comorbid problems with similar features. To delve a little bit more into this, I just wanted to break down the specific examples or the specific etiologies. So starting first with visceral hyperalgesia, that this can occur when there is the visceral afferents have been injured or are sensitized. When this occurs, not only is there pain localized to the GI tract, but it also results in a decrease in how much distension will result in pain signal generation. So this can present with pain that's associated with gastric feeds when there's normal distension in the stomach. It can present with jejunal feeds, and it can present prior to a bowel movement when the colon is distended. The one example that has been identified in the literature that can result in this is Nissen fundoplication surgery. In addition, what I'll call the relay center that receives sensory signals, the thalamus in the central nervous system, when this is altered, this will result in central neuropathic pain, which can then result in both general pain generation as well as pain that is again localized to the gastrointestinal tract and can present as an altered threshold to how much distension is needed to generate a pain signal. And then finally, I think many are very aware that how the altered autonomic control in the central nervous system when there's alterations in the hypothalamus can result in autonomic dysfunction that can both cause general discomfort, pain localized to the GI tract, as well as the expected other features of autonomic dysfunction. What I also want to highlight is that chronic pain, as well as acute pain, will also stimulate the autonomic nervous system and result in some of those similar features. So tachycardia, hypertension, and sweating as examples. And then finally, these three sources of symptom generation as chronic pain sources will also exacerbate any underlying spasticity and dystonia that the child has. So it requires us to consider that such children can have dystonia that contributes to symptoms. They can also have underlying symptom generation that then exacerbates the features with these problems. And though this seems challenging initially, I'm going to work through some strategies to break this down. And then finally, the take-home point from this slide is that children with severe neurological impairment have more global alteration in the nervous system. That means if they have one of these problems identified, they're at risk for the other problems. I also want to highlight the definitions and terms that we use for clarity. So I provided the working definition for severe neurological impairment. I do want to also get at the terms agitation, irritability, and then include in that neuroirritability so that we're clear that these are descriptive terms indicating to us that a child is not in a calm state, and that then it's alerting us to a problem in need of identification, and that the differential for these terms would be problems such as acute drug toxicity, acute medical illness, as well as acute and chronic pain. And then also, what I would highlight again for terms for consideration is I provided this proposed term of neuropain and the reasons why, and how that then helps us identify a mechanistic reason for symptom generation. But I also want to highlight, given that there, again, is not truly ways to distinguish one of these sources from the other, that means we cannot currently localize to the specific problem. And that's in contrast to neuro problems that can be localized in the central nervous system, the problems of spasticity, dystonia, and seizures. Obviously, one aspect of treating pain is we first have to identify that pain exists. What I really want to highlight from this is that it's very clear in the literature for the past 20 years, as there's been more and more studies, what features will be observed in such children who are experiencing a painful event, often referred to as pain behaviors. So these are kind of the self-explanatory features that we can look for. Are there changes in vocalizations, facial expression, difficulty in being consoled, changes in interactivity, the known physiological responses, and again, this aspect where there would be changes in baseline tone, the posture of the child, and the degree of movement that the child is experiencing. And in fact, movement, tone, and posture are the most common pain behavior features seen in such children, not surprisingly. There are pain behavior assessment tools that can be utilized. The best way to think of them is that they're of critical importance in acute settings, such as in the post-op period. And then they can become tools, though we should not become overly dependent on these tools when we are following a child's potential pain over time. When such children present with pain behavior features, obviously one important part that is part of this process is always coming back to the basics of a comprehensive history, exam, when needed, blood and urine diagnostic tests. If there's not a clear etiology, to look at further diagnostic tests such as abdominal ultrasound, and then diagnostic trials. So in this case that I'm depicting, this is a 3-year-old who meets the criteria or meets that definition for severe neurological impairment. She's known to have spasticity and is on baclofen. She has seizures and is currently on 3 anti-seizure drugs. She's on clonazepam that was started kind of for the combination of managing both problems. She's on a proton pump inhibitor that's been recently increased and has had another recent assessment for pain sources. The next step is what I'm going to call screening for neuropain as a potential reason why a child is having recurrent pain experience. The way that I would just summarize this is that we identify that a child meets that definition of SNI, that our history identifies that they have recurrent episodes that include pain behaviors, and that we identify that either there's no source that's identified or that there's inconsistency in the sources that are identified, and that the child has other features that we would know to be associated with chronic pain in general and with the specific causes such as GI tract symptoms, autonomic symptoms either due to autonomic dysfunction or stimulation of the autonomic nervous system. And that the child, like was the case for this child, the child can also have seizures and may have events that are seizure-like, but may not have an EEG correlate if there's a video EEG obtained. And the references that I have here, the one from last year is focused solely on chronic pain and going into more detail about this, and then a link that summarizes a little bit more detail about this process. But there's certainly going to be some aspects that can interfere when we don't have that simplicity of a test to tell us what the problem is. One gets at knowledge of drug use, and so being comfortable and knowledgeable so that we're confident that we can both manage and not cause harm from the medications we use. And I'm going to get back to an example of that. And then I'll get into these next 2 points, starting with cognitive bias. And I'm sure that you're familiar with how cognitive bias is an important aspect in healthcare, so that we can just kind of check in to our way that we are oriented to what problems can cause the features that we're seeing. And I'm going to focus on the example of anchoring to positive tests, and especially the conundrum that children with tracheostomies may have a positive culture that is due to colonization, but if the child's having recurrent symptoms, it may be viewed as an etiology for those symptoms. Or the example of children, which was the case for this child, of having intermittent catheterization, which can increase the risk for a positive urine culture being colonization. So how can you distinguish when it's due to an underlying chronic pain source versus in colonization versus the cause of symptom generation? So the example of this child that I presented, we were able to look back at history and see that the majority of times that the urine analysis had a low white cell count. And so what we reassured the team, we are not looking to look critically at decisions to treat those positive cultures, that one makes the best decision that makes sense at the time that it's made. Instead, it was to look to raise a question. Maybe some of those cultures were colonization, and that there is an underlying chronic pain source that's the reason for the breakthrough symptoms. And then the next part that can interfere is certainly parents deserve to understand why medications are being used, so that they can feel comfortable when we're offering up an intervention for treatment, particularly so they're not feeling that we're medicating their child versus that we're treating the source of symptom generation. And so I always start by giving a basic overview of the difference between tissue injury pain versus pain generation through the altered nervous system. Then that way I can let a family know that though there is no test to confirm that this might be neuropathic pain, I know that with the information you were able to give me and help me better understand your son, that information really informs me that I know that your son is at risk for this type of pain and deserves a medication trial directed at that type of pain. And then in this communication, other strategies for communication can be also to anticipate and manage worries. One would certainly be looking at the worry that pain treatment will stop a new pain source, so that we can reassure that pain treatment will not stop a new pain source from being identified and will not stop pain from being generated from that new source. A second example is that in the initial phase of starting and weaning up on a medication for NeuroPain, that we can anticipate that increased sleeping in the first 1 to 2 weeks means that the drug is working, given that chronic pain can be very exhausting. If there is persistent sedation after we've gotten to a certain level, that we'll look at what makes sense and reassure that we will not allow ongoing sedation. And then certainly managing expectations, such as and acknowledging that this is a type of pain that we cannot eliminate. The medication will decrease the severity and frequency of episodes, but there still can be breakthrough episodes that are less severe, and we'll work through how we can manage those in real time. And then also the expectation, and I would say this is both for families and clinical teams, that chronic pain in such children cannot just be shut off quickly. It often takes time in the first 48 hours and then the first week, given that the overstimulated nervous system takes time to dampen with the strategies that we utilize, and I'll get back to that. I want to shift now. So we're considering that we have information that informs us that this child is at risk for that being that NeuroPain is a reason for these recurrent episodes and the features that we're able to identify. And we want to look at management. And what I really want to highlight is that chronic pain management involves all of these in equal measure, and I'll go through each one of them. Scheduled medication use, managing comorbid problems, acute on chronic pain, and then the triggers of GI tract distension and the environment. So the medications are well outlined in the American Academy of Pediatrics clinical report that I, along with Amy, developed. I should also mention that that clinical report has been accepted for revision. It'll be republished with a few added references to make it more updated. But this guideline for medication utilization is based on the limited data and literature that we have relevant for this population of children. The broader level of evidence from adults who have central neuropathic pain due to such problems as a cerebral vascular accident or due to multiple sclerosis. And what I want the audience to know is that even in adults where there are a vastly greater number of individuals to study, in many studies, they are not able to identify a linear approach to medication use. In fact, their first line medications are 2 or 3 different, depending on the ones you look at, are 2 or 3 different medication categories. The reason why in the clinical report we start with a gabapentinoid is also factoring in safety, and then these second and third line medications. And then these guidelines are just that. They do not dictate care, but they help just guide considerations as to what might be, again, the second or third line added medication. And then those medications obviously are intended to decrease the frequency and severity of episodes, but there's also a role for as needed medications for breakthrough symptoms. When starting a medication and anytime we add, we always want to be very clear on what we are measuring for to determine that there's been benefit. The obvious one is pain reduction, and it's both severity as well as frequency. But there are other outcomes that we can also look at that get at more general increased quality of life. So it might be attendance at school, which is one that I routinely measure, improvement in sleep. Another important one is improved feeding tolerance, by remembering that these neuropain sources can in some children create GI tract pain. GI tract pain will limit the ability to give feeds. The second reason why is that when a child is in pain, they tense more and have increased metabolism. When a child is more comfortable, their metabolic rate will decrease. And again, the amount of calories needed to maintain or achieve the weight that we wish to see is more easily achieved. And then obviously the one, though we don't routinely measure this, is the improved outcome for the family. I also want to give just a brief acknowledgement that anytime there's a medication started for neuropain, and if there is persistent sedation, to not just assume that it's the last medication started. Sometimes what can occur is that other medications were started that can also be sedating. If that medication was treating the end effect of chronic pain, but that the medication doesn't treat pain, we might see an increased sedating effect from that medication if we're now have a medication that has better ability to manage the underlying symptoms. So in this child's case, it involved slowly weaning down on clonazepam and ultimately weaned off of this medication. And the initial medication that was the last one that was started for NeuroPain was then continued. And I mention this because I've certainly seen, understandably, many times where the medication has been discontinued, such as a gabapentinoid, yet we might be actually discontinuing the one that has the greater benefit for symptom control. The next problem, and I just want to highlight a strategy, and because this is a major challenge, but I think it's a manageable challenge, and that is when there are neuro problems that we can localize to the central nervous system in a child with SNI, and that child has episodes that include pain behaviors, to give, again, consideration that there might be both the neuro problem as well as an associated NeuroPain triggering chronic pain symptoms that then exacerbate spasticity and dystonia, or that may be seizure-like in some of their presentations. So my strategy is to just alternate between the two considerations, so that if baclofen has been started for spasticity and there continue to be recurrent episodes with muscle spasms, and those episodes include pain behaviors in addition to muscle spasms, and the child might be at times considered to be irritable, then my next medication would be to alternate with a Neuro-Pain medication. And then the same strategy with looking at symptom clusters. So what else does the child have? So the child might have episodes with pain behaviors as well as poor sleep. So then it might make sense to select a medication such as a clonidine dose at nighttime, or a higher dose of gabapentin in the evening, or that my second add-on medication might be a tricyclic antidepressant. So I just wanted to acknowledge that if you really look at spasticity, dystonia, and then these neuropain problems, the medications I listed here are 11 different medication categories that can be considered. So my idea is, how can we create a little bit more order out of chaos, or what I call here medication mess management, or I guess the other 3M, given that I'm originally from Minnesota. And then here, I did want to look at acute on chronic pain, because we have to consider both breakthrough pain due to the underlying chronic neuropain source, as well as a new nociceptive source. So first is the benefit of anticipating breakthrough pain and proactively developing a breakthrough care plan anytime we're initiating a medication for a neuropain source, and whether we consider that it's visceral hyperalgesia, autonomic dysfunction, or central neuropathic pain. And the idea is that way we can partner with parents, we can learn from them what have they found helpful, and then we can make sure that we have a consistently developed care plan, so that we define what are the presenting features that are specific to this child. So someone new to that child, such as a bedside nurse, then can look and see what those features are. The importance of reminding all providers to start with routine interventions of personal care and repositioning. The AP clinical report has a lot of detail on non-pharmacologic strategies to try. And again, this is a partnership with parents. What have they found to be useful? So some families will say a warm bath, or headphones with music that has a lot of bass with vibration. We can also offer up strategies of a weighted blanket, a vibratory mat. If the child has a vibratory vest, the parent can use that as another form of vibration. Massage, given that deep pressure, is another form of non-pharmacologic strategy. The next is remembering that these neuropain sources can change how much distension is needed by decreasing the amount of distension needed to generate a pain signal. So looking at lessening GI tract distension in the moment. So it can be holding feeds during an episode and waiting till the child's been calm for an hour before resuming feeds. Or it could be a trial of a suppository to see if promoting a bowel movement will then decrease colonic distension. And then certainly the role of as-needed medications. And a practical approach I would say is, if I'm using, if the parent has been using ibuprofen or acetaminophen and it's consistently not very helpful, and so I'm adding in a prescribed medication of clonidine or short-acting opioid, I would then have the family give that prescribed medication at the same time as either ibuprofen or acetaminophen, rather than doing it in a stepwise manner. Given that it would be a safe strategy, and then it gets two mechanisms directed at pain management initiated at the same time. And then the final is just a practical consideration of expectation that onset of initial benefit is obviously partly the onset of the medication use and the strategies that are being used. So again, it's not an expectation that we shut this off within minutes, but that we're looking to see a gradual benefit being noted in the first 30 to 60 minutes, and then resolution in over several hours. And then this other part is we're partnering with families as to when to assess for a new nociceptive source. So always factoring in parental worry, but also proactively acknowledging that anytime there's a new feature that you don't typically see with these episodes, if it's more severe than usual, or if it's not responding to the breakthrough care plan as it typically would, that would be a time to initiate a new nociceptive source. So in this child's case, it was a urinary tract infection with an elevated white count in the urine analysis and a positive culture. I also want to briefly just acknowledge that there are times to review the estimated calories that are being used. And the reason why is there's some limited literature that really is highlighting that there's a subset of children with severe neurological impairment who expend 30 to 50% less energy compared to the historical group of children who are non-ambulatory with cerebral palsy. And also to remember that this can be a vicious cycle for two reasons. If the child has chronic pain, they'll be expending more energy. Calories are increased, which is adding more volume that can further add to GI tract distension, and then further increase metabolic expenditure. There are times when I will actually just cut back, and when I cut back, I typically will be considering a 25 to 30% decrease in calories while attending to the protein and micronutrient needs. So one simple way to do this is to switch the child to one of those low calorie formulas where it's 0.6 calories per milliliter, so that to provide a similar amount of protein and micronutrients. Those who have the lowest calorie need, you can identify from history. They're the children who, when calm, will have at times intermittent low body temperature, less than 35 to 36 Celsius. When comfortable, they'll have minimal movement of extremities, or that we might identify that the child's function has been gradually declining over time, which again would be decreasing the child's overall metabolic rate. And I'll just give a quick anecdotal example that even with my having cared for a lot of children, in a child where I felt that we were really careful about that balance of calorie estimation and a child on multiple medications for Neuro-Pain and comorbid problems. And there was this 1 month recently where she just continued to have persistent symptoms despite adjustments in her care plan. And based on where she was at with her calorie estimation, it ended up being about an 18% decrease in her calories. And within less than 24 hours, her mom and her primary nurses said she was like a new child. And she's had now several months of persistent improvement in her symptoms. And then finally, the worry of weight loss. Again, if we improve symptoms, we'll decrease the energy expenditure for the child. So often you won't see weight loss, or it'll be so transient and then a slow gradual increase again. One other trigger along with GI tract distension is hospitalization. And the way I would frame this is that hospitalization is often necessary, while we also remember it can also contribute, as it's a very stimulating environment. And one of the strategies that can help with symptom reduction is a calm environment. If a child comes in due to escalation and the initial assessment hasn't identified a new source, and we're shifting to a goal of symptom reduction, that we should really think as a team strategies to better achieve that. Again, also recognizing that reduction takes time. The role and benefit of team huddles, particularly with bedside nurses, to review strategies and goals, and also to discuss and frame these goals with parents along with other specialty team members. I break it down into 48 hours and then 1 week. So the first 48 hours, these would be strategies I would use in the hospital or at home. Holding feeds, giving hydration with an electrolyte solution by feeding tube, maximizing the calm environment in the hospital by using our delirium protocols that we often develop within hospital settings, use around-the-clock medications, including acetaminophen and ibuprofen. Sometimes I'll use one, sometimes I'll actually use both for the first 48 hours. Have an as-needed medication, either clonidine or a short-acting opioid, and then I'll get back to this other part about hold orders. then in this child as an example, either with the first medication that's added, we get some benefit, but not the degree we were hoping for, or that later in life, there's an escalation of symptoms without a clear cause, that there clearly are times to consider a second or third line added medication. This is just to highlight, again, from this chronic pain article, a methodical approach to this. But what I do want to start with is that if we look at data in adults who have central neuropathic pain, over half of them will be on 2 or more medications. And I wanted to make sure to highlight this so that we remember it's not failure if the first drug doesn't work. It meant that this is a difficult form of pain to treat. But before I add a second or third medication, I always want to get back to the basics. A comprehensive history, exam, diagnostic tests, and then looking for other considerations. One example is that given that such children are seen by multiple providers, has the child been recently started on other medications, where now we have 3 medications that each have anticholinergic effect, recognizing that there are many medications that have that as an added effect, which might not even be the primary reason for using the drug. So we could either get some drug effect through a high anticholinergic effect, or that it can contribute to further slowing of the intestinal tract with associated symptoms. And then other review of management of constipation, which would be one of the triggers with GI tract distension, that strategy for how we manage comorbid problems. And then finally, drug dose maximized of drugs that are already in use, and then event frequency. So I'm going to use the example of clonidine. I do want to acknowledge that in the American Academy of Pediatrics clinical report, there is some literature that helps guide us in terms of the medication dosing of medications such as gabapentin and clonidine, so that we make sure we're both have a sufficient trial and that we've also maximized the drug. So knowing how high can we increase these medications. The reason I wanted to highlight clonidine is understandably, we want to improve a problem, but we don't want to add risk. And everyone's familiar with the risk of hypotension from clonidine. I want to frame this risk that the main risk from hypotension is the risk of standing, having orthostatic hypotension, falling, and then injuring oneself. So we don't have that risk in children with SNI who are unable to stand independently. I want to give then an example of also the importance of looking at our blood pressure tables. I've certainly learned over the years the importance of doing this. So this was a recent example of an 8-year-old girl who in the hospital was started on clonidine. And when they saw that her baseline blood pressure was consistently right around 110 over 70s, they used that as a guide to write a hold order. We were able to later point out and validate their decision-making, but then to highlight that that baseline blood pressure was actually the 95th percentile for her age and length, and that the hold order was the 50th percentile. And what was happening is that the clonidine was often held because it would have benefit, blood pressure would be at an appropriate baseline. And so it was a reminder that pain can cause an elevated blood pressure. So once that hold order was eliminated, it was given consistently. Her treated blood pressure was consistently at the 50th percentile. And then there was even blood pressures when asleep in the hospital that were slightly lower, which is well defined in the adult literature. And then finally, I just want to highlight the literature that does talk about dosing for clonidine. So there was an article in 2006 looking at its use for spasticity. And then there was a more recent article in 2017 looking at the outpatient use of clonidine for dystonia. And these were 2 different centers, but interestingly, they both identified the same average dose for clonidine of 20 micrograms per kilogram per day. So if this was an enteral dose, this would be almost 7 micrograms per kilogram per dose 3 times a day. If it was a clonidine patch, it would be a 15 kilogram child that would be on 0.3 milligrams per 24-hour patch to be at that average daily dose of clonidine. And then this article from 2014 that is a good review of management of dystonic crisis or status dystonicus and using higher doses of clonidine for that specific circumstance. And then what I want to end with here is the question when you have a problem without cure is how we partner with families to think in terms of, have we reached good enough? Because there's always that balance of considering add-on medications so that we can achieve more benefit, while also looking at would we potentially add more risk, particularly with sedation, the more medications we add. So this, I'm just going to offer up my general rule of thumb, which is that if on average over a month's time period, that each week there's averaging, say, 2 episodes per week, and that the episodes respond well to the breakthrough care plan. And that might even look like that one week there might be 4 episodes, and then there might be no episodes another week. But that if on average that's what we're achieving, we can then ask and partner again with parents that, is that good enough? Should we try that second medication? And then particularly with adding on a third medication where there's less of a chance of adding as much benefit as we achieved with the first 2. But again, that recognition that there's no right or wrong answer, but again, a shared decision on what makes best sense for this family and this child. And so it really is looking to see, well, what would success look like for this child, of the difference between no symptoms versus fewer symptoms that have good response to the symptom reduction plan, and that this can also be a process that evolves over time. I'm going to just end with just an example of a more recent child, just to show again decisions about polypharmacy. And this is a 16-year-old, again, meeting this definition of severe neurological impairment, whose gross motor function level 5, and is best estimated either severe or profound intellectual disability, but as is the case for really all of these children, she really is very responsive to her family when she's comfortable, smiling and happy. But she's again having more frequent episodes that include these pain behavior features of crying, tears, facial flushing, sweating, tachycardia, muscle tensing. She's already on a fentanyl patch and gabapentin, and mom was wondering, is she anxious? So her primary team added citalopram, which was reasonable to try. When consulted, what was able to be highlighted is that citalopram is a SSRI, selective serotonin reuptake inhibitor. That medication class is not effective for neuropathic pain. So what we offered in contrast is to use properties of both serotonin and norepinephrine. So we offered switching to a tricyclic antidepressant instead of citalopram. So this was then weaned up slowly in the manner that's outlined. And then simultaneously, the citalopram was weaned down. And the second thing that was done is the gabapentin dose was increased a little bit just to maximize it. And then the final thing, by recognizing that a tricyclic antidepressant does have an anticholinergic effect, we just offered, why don't we see if the glycopyrrolate that she's on, either we have a lower dose or maybe she would do well being off of it. And then that combination was able to achieve the goal of a significant improvement that was sustained. And then finally, I just also want to acknowledge that such children have chronic problems without cure. So I just want to orient to thinking about where is the child at on their trajectory of life when we're making these decisions about symptom management. So there are many problems that are without cure for such children. Seizures, spasticity, dystonia, chronic neuropain, respiratory status, feeding intolerance. And the way I've come to depict it is that always thinking, have we achieved our goal of thriving, which is what I just define as achieving a desired level of health and quality of life, that parents help us understand, have we achieved that? When there is increase in these chronic problems without cure, And when there's decline in health and quality of life as associated issues, then we can take a step back. What more can we add to the care plan? And then honest reflection, how likely are we to achieve that? And that question of how modifiable is it? And then finally, the context of, are we at a more irreversible phase? And I mentioned that especially in symptom management, because that'll make a difference in terms of symptom managed strategy decision-making when we're at more of a continued decline in these areas. So in summary, and this is perfect for opening up for questions, but in summary, that I hope that this just helped orient and reinforce great care you're providing, and then give further consideration to the difference between acute and chronic pain etiologies and mechanisms of symptom generation. We have CNS sources that we can modify, though we can't identify them with tests, though I offered up some information to look more into that can help screen for when to initiate treatment for CNS sources of pain, consider the triggers of environment and GI tract distension, look at chronic pain, chronic management that gets at scheduled and as needed medications along with breakthrough symptom care plans, and modify this as needed through the lifestyle, the lifetime of the child. And then certainly I'm happy to provide any references that would be helpful. I have the further references here, but I'm always willing to be contacted. But with that, what I'm excited to do is open this up, and hopefully there'll be some questions that can be discussed in more detail, because I know I wouldn't have provided all the answers to these complexities. So thank you so much.
Julie, thank you so much for that incredible grand rounds. I can't even talk about how excited I am about it. And so we have some questions that are coming into the Q&A, and please, everybody, feel free to throw questions in the Q&A for us. And what I wanted to do is just start out with one of the questions. I've always been very affected by your thoughts on the interaction between visceral hyperalgesia, irritability in these patients, and feeding. And oftentimes when we suggest cutting back on feeds or not going back to the child's full feeds, the physicians that are consulting us and also the parents get very nervous about that line between meeting the child's nutritional needs and meeting their comfort needs. And I was wondering if you could talk a little bit about how you navigate those waters with both of those parties.
Yeah, yes. So thank you, because this is so critically important that, and also with all of these complex decisions, allowing time, because especially if it's during the acute phase and feeds are on hold, that gives right there already 48 hours in terms of thinking, well, what calorie goal are we seeking to achieve in the future, and do we wish to adjust that? The second is what I do with both teams and parents is to rethink how we think of nutrition by breaking down that we can always assure that a child is receiving the required protein and micronutrients. And then we can think of calories as the part we're going to adjust. We can provide protein and micronutrients either by providing that lower calorie formula, because essentially you're providing less calories in a volume that will give a greater amount of protein and micronutrients. Or the other way is obviously we can also supplement if we need to. With parents, my strategy is I don't talk in terms of a percent decrease. What I'll offer up is what might make sense is that we seek a goal. I'll just arbitrarily say, let's say the child's getting 100 milliliters per feed. So I want to decrease the amount to then 75 milliliters, so a 25% decrease. That way I'm giving a number of what we'd be giving, which as opposed to talking about a percent decrease. The second is to absolutely spend time with parents by assuring that we're not cutting back on nutrition for health, we will assure that they'll receive the nutrition that they need while we figure out what is the true calorie need. The part that I found the most interesting, when I take the time to describe how pain makes anyone tense. If you even think about yourself, if you're in pain, you tense. So then that gives a visual for a parent where they can even think of it themselves. So if a child has chronic pain and they have spasticity, the amount of tensing is that much greater. So their calorie expenditure can be quite high. So if one of the things that's contributing is the volume of feeds, and then we decrease symptoms, we'll be decreasing how much energy the child's expending. Or separately, once, and even just the flip side, when I don't decrease calories, I routinely see kids also have weight increase if you've achieved improved symptom control, and we have to start cutting back on feeds. So, and it's interesting, when I spend time talking with most parents, once they grasp that, they're very comfortable with it. And then the final thing is absolutely also with teams. And I think the biggest thing that I can highlight as a concept is what the data that's used to estimate nutrition in this group of children is based on the WHO guidelines for malnourished children. Those are children who don't have access to food. So that means that they're either deficient in protein or they're deficient in protein and calories. So we're not children with SNI with a feeding tube, we're going to ensure that they're receiving the protein and micronutrients they need. So that, again, it's quite different than the data that generated these decision making. There's a lot more I could talk about, but I'll just kind of stop it there.
Well, that was just wonderful. I really can't thank you enough. You're speaking to my pediatric rehabilitation heart when we think about how all of these different things play in together. And when we think about pain, we should think about in the context of all the other things going on for that child. We have a couple of questions from the audience. One is about the use of hormones to aid in menstrual suppression with the hopes that we're reducing cramps and other side effects. When that's done, do you also see positive effects in other areas, such as reduced parasympathetic symptoms or muscle tension, or potentially even the option to decrease other medications that you might be using at the time after you initiate hormone therapy?
So the best I can answer is I have not observed that. That the role is, and so I kind of think of it as there's a role for using that therapy for other reasons, and it can also clearly decrease on the menstruation symptoms, but I've not seen that then translate into symptom reduction in other areas.
Great.
Thank you. That's an important question.
Yeah, it's an important area because we often talk about menstrual suppression as a potential intervention. When you are using tricyclics, how do you decide your preference, and is that based on age of the child, and what is the youngest age group which you use tricyclics in? So
the latter, I might not remember absolutely, but I know I've used tricyclics even in children less than 12 months, but probably the lowest is around 6 months. And the reason for that is kind of multiple fold. There really isn't data in younger children. So gabapentin, they've looked at the pharmacokinetics as young as 1 month, so that at least helps us. And now there's more data from the neonatal period. But with tricyclics, and the other reason is that the children who are born, and I'll just use the general term irritability, that especially the children who have the history of hypoxic ischemic encephalopathy, that the irritability tends to start to manifest kind of 3 to 4 weeks out. There's interventions being used. And so I kind of think of it that in that initial phase, in that younger child, there might be reasons to use gabapentin along with, say, methadone as another medication category. Again, I think the best way to say is I'm now just speculating and talking about, but it certainly can be used at a younger age than just from an experiential standpoint. And then in terms of which one to use, what I've kind of noted is in adults, they recommend more nortriptyline, but that's purely because is viewed to have a lower anticholinergic effect. I suspect that in children, even though we worry about the anticholinergic effect on gut motility, that it doesn't make as much difference. It's more that the elderly population is so sensitive to the anticholinergic effect that I can understand why they focus more on that. In children, I can say at all ages, in the childhood ages we care for, that it probably is not important, and it's use what you have available and what's available in a liquid form if needed.
Oh, that's so helpful. And we're back to another question about feeding. And that is about the difference between using continuous versus bolus feeds and how that might change in how you need to manage their caloric needs. And do they do better with more time off of tube feeds or vice versa? So I think after that, we'll probably need to move to wrap up after that question. So I'll pass it back to Scott.
Okay. So the first is that this is one of these important non-pharmacologic strategies, is absolutely start with simple things like feed volume. For some children, I'm sorry, not feed, but the feed rate. For some children, that will be enough to help lessen that as a contributing strategy. And in fact, it's a nice thing to start with if a child's already on medications for Neuro-Pain. Children who have significant gut symptoms, interestingly, even when you switch to J-tube feeds, they tend to still have some degree of symptoms. So the flip side is that it's hard to say that bolus with some time off versus more continuous with a lower rate, that I can say that one is definitely clearly better than the other. That's kind of that art then of navigating with families. Then I guess I'll just kind of stop there from a time standpoint, because again, that's an important one, but it's a strategy for consideration. And then, but if there's still symptoms, rather than, I guess the other take home point I would say is, if a decrease in the feed rate isn't achieving it, in my mind, then that's a child that still has a very stimulated neuropathic pain generation to, again, look at either maximizing drugs, considering a second add-on one that you probably aren't going to achieve it if with just continued focus on that as a strategy.
All right. Well, that concludes our hour, but Dr. Hauer has generously agreed to join us in the after session meet and greet. The link to that is in the chat box. Colleen has very helpfully put that for us in the chat box. There is the Zoom link, and then also there's a password required to get into it. Dr. Hauer, thank you. Thank you so very much for joining us today and for giving us a bit of your expertise on the care of these very challenging kids and their families, who I think we have a long way to go in helping them live their best life. And so thank you for helping us get there. So with that, we'll conclude this session and head on over to the meet and greet. Please, please, please join us.